Just real quick, again, I want to thank Mary for coming all the way from Alaska. Thank you. And she's going to talk about this amazing exercise that they just did in March, the end of March, that did lots of great stuff. Interstate patient movement, the federal medical station, and how they accomplished all of that. And she's going to have a lot of great pictures, so I'm pretty excited to hear this one. So I'll just turn it over to you. Thanks, Mary.
Alright, so Alaska Shield, Hale Borealis, is an exercise we do about every 2 to 3 years as a state. Usually we just call it Alaska Shield, but for this exercise we added a Hale Borealis piece. Hale Borealis, you've heard of the Aurora Borealis, right? Well, Borealis just means north, and Hale, if you're hale and hearty, you are healthy, so it's healthy north. And we called it out because we did so much as part of this exercise, so we wanted to have kind of our own identity for that. But it became even bigger than we had imagined when it became a national capstone exercise. How many of you have heard of a national level exercise? Well, this is what they now call it a capstone exercise, and instead of being done every year, it's done every 2 years, and it has a little different concept. And interestingly, I heard feedback from the feds from this exercise that they actually learned something in this exercise, whereas in the earlier top-up exercises, they really didn't learn anything. So we'll see how that's true. As Dawn said, it was the end of March. It actually went through the beginning of April. So it's 20 days exactly since we finished up with the Alaska Shield. So you're actually the first audience to hear anything about it from us. So in fact, I just got a draft after action report in my email during the previous speaker's presentation. So I was like, what did they have to say? Is there anything I can add to my presentation? All right, so with that introduction, let me proceed into the show here. So we said it was a national exercise. Some of what I want to convey to you isn't to help you understand the details operationally of everything, but more importantly, kind of the broad concepts. And here's a concept. If you're going to be part of a national capstone exercise, understand that there are going to be a lot of people playing with you, and just in general, a lot of people. So Alaska Shield was composed of all of these different exercises, and actually there's more than this. So I'm going to call out a couple of the help ones. Ultimate Caduceus is the U.S. Transcom exercise. You'll get to know them during this presentation. And Noble Health Saver is the Health and Human Services exercise. And Vigilant Guard and Ardent Sentry are military exercises along with Arctic Edge. And then there's Eagle Horizon, which is a leadership exercise. In other words, everyone's coming to play. One of the things they did in the exercise was they actually built a temporary port. Because if we had an earthquake in Alaska, the port of Anchorage, which is the main conduit for all of our supplies arriving from the lower 48, would probably be heavily damaged or destroyed. So they actually brought in, it's called a joint logistics over the shore temporary port. That in itself takes 700 people. So the population of Anchorage and surrounding villages grew enormously during this exercise. So if you're going to be part of a national capstone, just know it's going to be big. And one of the reasons why they picked Alaska Shield was this is the 50th anniversary of the 1964 quake. I heard a little bit earlier about an earthquake that affected part of Virginia,
Yes.
right?
It was like a 5.2.
A 5.2, so we're talking 1964, a 9.2. Second biggest earthquake ever recorded. Largest in North America. Only Chile can outdo us. So now in 64, remember Alaska had just been a state for a few years. It was still very small. So the casualties were in the hundreds rather than the thousands or 10,000s that are predicted today. But we know that we're just as likely to have an earthquake now as then, and so that was the scenario we picked for the exercise and the reason why we think it's so important to test those capabilities. All right. Okay, now these slides I'm going to go through really quickly because again, the idea is lots of players, and the local levels you can see these are all of, we call our is it counties here?
Cities and counties.
Cities and counties. We have cities, villages, and boroughs. Boroughs are the regional entities. or rather they're, Don, how would you?
Kind of like a rural county.
Like a borough county, yeah. Sort of a county. So we had all these cities and boroughs participating, and if they're in brown, that means they were actually part of our medical piece of the exercise. And then the next slide. So at the state level, we had all these departments participating. So we had our emergency management partners, all our public safety partners, transportation, all the things that would be really important in a catastrophic response. We had corresponding players at the state level, and probably our most important, other than emergency management, were our National Guard. Amazing. We've always had problems figuring out what roles to give them and getting follow through, and in this exercise it was splendid. Highly recommend those relationships with the Guard. And the next slide shows our out-of-state participants, and you can see how many Guard members there came from other states to help us. Kind of like getting EMAP, Emergency Management Assistance Compact assistance from other states, except you're getting them from the Guard. And in the first 72 hours, they have a lot of flexibility in what they can do. After that, the roles start clamping down on them. They have to get all kinds of permissions, but they can do a lot at first. So because we couldn't ask the Alaska National Guard to do everything we needed, all of the Guards who wanted to play came on board. So you can see there's a whole lot of those, as well as Washington, Idaho, and Oregon, as part of our Region 10, as FEMA divides up the regions. So again, here's a general idea, not to understand, not to be able to list every player that we ever had. Okay. Now we get to our federal counterparts. This is where it gets really, really, really big. I think our numbers are somewhere around 2,500 players in this exercise in Alaska. That's not counting the ones who were trying to add a CPX, a command post exercise, on top of the full-scale exercise. Because remember, everything we're doing for real. But then we have players back in the East who want bigger numbers and more stuff because they're trying to think, what would this really be like in a catastrophic? Well, you can't exercise everything. You can only pick certain things. So our most important partners for us are U.S. Transcom, Health and Human Services, mentioned them before, Coast Guard, Joint Base Elmendorf-Richardson, which is our base in Anchorage, and our whole National Guard headquarters. But you can never leave out your volunteers and your non-governmental organizations. Our primary NGO that we worked with was Samaritan's Purse, and I'll be telling you a lot about them as we go. But this list also includes our private participants. Every hospital in Anchorage played, and every hospital in either a sending or a receiving community played. That's a lot of hospital plays. So here, just to give you a little bit of a quick idea, in Fairbanks, they were the receiving end for our transport that was in-state, and they set up their Western medical system as well to accommodate that medical surge. In Juneau, they had mass casualty and mass care, but we weren't doing anything and playing with them as a state, or as the state. And in Anchorage, they were working with us on doing hospital evacuation, and they're responsible for transporting patients by ground. So they worked with us on the transport side. Then we had the Matsu Borough. That's the borough in which we housed the Alaska Medical Station, which is a 250-bed capacity. And we did that at their fairgrounds, and they were the ones who said, "Hey, we're overwhelmed. We need your help. We need support for 250 patients." So that's why we worked with them. Not to mention they're only 45 minutes outside of Anchorage, and it was free. We also had Cordova, and let's see who else is on that slide. Can you back it up one? I think there was one other. Cordova played on their own. Valdez sent patients to Fairbanks, full-on activation of their hospital, and Kodiak sent us patients as well. So you get a sense, if you look around the state, you're seeing that, oh, it's not just Anchorage, it really did involve a lot of the state. All right, and then one more slide on our local participants. In Unalaska, they were doing a medical surge, but they did that at the local level. They didn't ask for state support. Kenai Peninsula, again, they did local things, and Ketchikan, all those things were done at the local level. They didn't require anything that they were doing, they didn't require our state support. So here's really what we did. Insane, I will tell you, never do this. Do not exercise for 7 days. Do not do 3 major events. I just highly recommend that. It's a lot to chew on, but we wanted to try out all these things. And these are actual photos from our exercise. Photo at the bottom left is from the medical station, and the remaining 2 slides on the bottom are patient transport, and the one on the top there is also our medical station. We'll be showing you a lot more about that. So here's what it looked like. Just keep hitting the button. We had to activate our EOC when the event started, and we have an EOC that's specific to health, Department of Health and Social Services EOC. And we did that because we immediately wanted to stand up that medical station. We knew there'd be patients coming quick, and we wanted to test the capability to get that up and running quickly. So we did that, set it up Thursday, ran it Friday and Saturday, did our patient movement. Preparations for that at the local level, the surge, was Thursday and Friday, and we actually transported patients on Monday. And for our out-of-state or interstate patient movement, we did that with preparation on Sunday, making sure we had the patient lists all right. Monday was actual transport, and Tuesday was just demobing everything. And then just for fun, we finished up operations and had a hot wash. Actually, we had lots of different hot washes on each one of these little different pieces, and that was our 7 days. We were exhausted. Okay. So what is an Alaska medical station, and why should you all care about an Alaska medical station? For this reason, it used to be a federal medical station. We're the only state that has ever been gifted a federal medical station, but they're available to any state whenever there's a need. Okay? So everything that we learned, you can use. So, what is it anyway? Well, it's not a bunch of tents with a bunch of stuff. It's just a bunch of stuff. Now, when you order up a federal medical station, it comes with somewhere between 110 and 150 people to staff it. But guess what? They didn't gift us people. They just gave us stuff. And so it's been sitting in our warehouse for a couple of years, and we're going, if we really had to use this, we just don't have a clue how we really make this work until the feds came. And we know in Alaska, how long do you say you need to self-sustain before help comes? 2 days? 1 day, 2 days, 3 days?
5 to 7.
5 to 7?
A week or two at least.
Week or two at least, yeah. We, best case scenario is 72, but for medical, we're like, not really. Yeah, more like 7. And our personal preparedness, we tell people 7 to 10 days. So okay, so we got to figure out something. We can't just say patients are going to have to wait at the door and, a good week, 10 days before we can get to you because we don't have any staff. So we needed to figure that out so we could address this potential shortfall in any kind of a surge capacity. So it's stuff. By the way, they didn't give us the pharmaceuticals. We had to buy those separately. And then now we'll have to resupply them now that we started that chain of events. So we can provide care for 250 non-acute special medical needs patients for up to 3 days. What kind of patients would those be? Since you train, I'm thinking
the elderly.
Elderly.
In Alaska, you're Native Americans.
Okay.
Yes.
What kind of healthcare issues would they have?
The Native Americans, I know alcoholism is major.
Okay.
And probably injuries, since they have so many remote areas. My daughter's the doctor that flies to remote areas.
Yeah, absolutely.
Yes. And she's shown me some pictures of the medical centers. I thought they were shacks.
Yeah, some of them are really minimal. Yeah.
We see a lot of chronic.
A lot of chronic.
And a lot of diabetes, hypertension.
Yes.
That's the one.
Yeah.
We have a lot of fragile diabetics because we do have a native population, and they're much more at risk genetically and honestly because we've kind of contributed to a ruined diet for them.
Yes.
And because in villages, do you know what the #1 thing that's transported is? Pop or soda, whatever you call the thing that I love to drink, Diet Coke. Except they don't drink diet, it's sweet. So we have a lot of fragile diabetics, we have a lot of dialysis patients. All of those are appropriate to a medical station concept. Okay, so we're saying up to 3 days, but it's Alaska. We'll think, okay, we can stretch that out if we can staff it, and we can wait for those 110 feds to arrive with support.
What are you doing with your dialysis patients? Where are you giving them dialysis? Because I would think
we're coming up with alternate plans to stretch out how long it is before they need, and they'll be some of the people that we would transport. Either in state or out of state.
Having water systems or chairs or staff to be able to do their treatment.
Really good candidates for transport, but meanwhile for the couple of days we can hold and work with them, but we wouldn't be sustaining them right? We'd just be keeping them as best we could and prioritizing them for moving out. Good question. No building. He uses whatever building of opportunity you have. So what we've done is gone through and assessed all the buildings that are anywhere near big enough. You know how much space it takes for 250 beds and all the stuff? 40,000 square feet. The building we used, the fairgrounds, was 20,000, so we started up about half capacity, and it was huge. Let me just say, it's kind of overwhelming. So, but it's modular and scalable. You can break it down. In fact, at the federal level, they're looking at breaking them down into 50-bed units. They find those are more useful, even in the more populated lower 48. It's meant to be for all age populations, and we actually beefed up our pediatric pharmaceuticals from what the federal cash is. And it does come with things kind of like pack and plays. I wrote that down, pack and play. But it comes with cribs and things like that, so you can you have some moderate ability to address things. And it's considered transportable, but it's not really. It takes lots of long haul system trucks to get the stuff in, and you'll see why in a minute. Okay, so that's what it is.
Another question.
Yes.
Do you have was there a lot of issue with like obesity and things like that with trying to like with the elderly trying to get them moved from? Because I mean, even with us doing shelters here for just 24, 48 hours, we don't have enough staff to get the elderly patients that are really obese from chair to chair.
Yes, it's absolutely an issue, and it also becomes an issue in patient transport. Why? We can cover it later, but I might as well tell you now. Because the planes are configured, they're meant to be sort of multi-use planes, so they're not just used for patient transport. It's provided through the military. They do all kinds of stuff with those planes. Well, it's not really configured for bariatrics, so when you add a bariatric patient in, it's actually taking up a whole rack of space because the way the litter racks work. So once you put in a bariatric patient, you're kind of losing some of your capacity to scale upwards.
Are you getting Borealis or anything like that with any of your
Yeah,
supplies?
that's what we're looking at. We are working on a memorandum of agreement with some of our durable medical equipment sources in Alaska to utilize some of their equipment that they have on hand and they're stored in their closets. And that may be, well, for using our after action, this is a great thing to do with exercises. Look to you know what your some of your shortages are before you exercise. You reveal new ones in the process. Use all of that to help come up with justification for why you need to get something, or why you need to provide training, or why you need more people to do whatever it is that you need. Whatever it is you need, use that as data. Make this exercise meaningful far beyond the time and the people that exercised in it. Make it endure. So make it a great report, and keep referring back to it.
Dementia patients and all, what are you? Because once you're moving them to another place, they go a little use.
Well, that's what happened. That's what happened to us in the Galena floods. Actually, when we moved elders out of the community, they decompensated fairly rapidly, and if they hadn't been in assisted living before, they actually went into assisted living. And there's some stories like from Galena. One of the elders, her spouse had passed away the prior year. And she just absolutely felt like she needed to get back to Galena because she felt his spirit there. Well, their whole house, the whole bottom floor, was out. I mean, you had something on the second floor, but she was an elder and couldn't go up and down. So it was a lot of work with the family to help her understand that wasn't going to happen right away. So you just get lots of those kinds of issues, and it is what it is. And if you're going to bring dementia patients, mental people with behavioral health issues, they actually require one-on-one attendance in patient transport. So you decrease your capacity for everything special that you're transporting. Your capacity goes down, and in some ways, it's the same thing is true for the medical station. The more individual care one patient provides, the less far your staff is going to go, or the more staff you need. So that's part of how you determine what you can handle. So. Let's see, was there anything we haven't talked about here? So you're not looking for the person who needs surgery. You're not looking to be a hospital. It's a lower level than a hospital. It's for the person who might have been able to, with a personal attendant, be at home, but they lost their personal attendant, or there's nothing, they have a personal attendant, but neither one of them can stay in the home. Those things are perfect for a medical station. It's great for quarantine. Hope we never have to use it for that. Okay, so right, I think. Oh, it doesn't come with its generators, food, water, or toilets. Now in Alaska, we think the fact that it's not transportable and it doesn't have all that stuff wasn't a good thing. So last year, using some year-end money that our department, which is a very large department, had, we convinced them to buy a rural Alaska medical station, or what we call the RAMS, and it is transportable, and it has its own kitchen and it has its own cupboard.
Oh.
So it can be deployed in an urban area that doesn't have a need for 250 beds, or it can go out to any of our villages. So that was a pretty cool thing. And the same concepts that we tested here we can use there. And we're gonna send that out to Seward on the Kenai Peninsula in August. We're just crazy. All right, next slide. So what is all the stuff that comes with it? Well, it's got a base support module, a base treatment module, a biomedical module, and a pharmacy module. All of which to say is there's a bunch of basic medical stuff, some things that'll help you deal with chronic care, special needs, things just that you need to help make things easier for the patient and for you as staff. You know, your wheelchairs, just simple things like hand wash stations if there's no water. How do you do that? So it comes with these little plastic portable hand wash stations. Very primitive, but it's better than if you don't have anything, right? And then you've got your pharmaceuticals. This all comes together with the 179 trials. I'll show you pictures in a minute. And travels on tractors. So down on the lower left, that's the comms unit that we send with it. We also built, and we have 2 comms trailers and comms backpacks that are smaller units, and then the in-between versions that it can all be sent out to any kind of an event, because what's the #1 problem you have? Communications. So let's see, you see some of the storage items on the lower left, and actually that's the first deployment of our medical station up top there. That's some of the mini cots that are laid out.
Have you had any issues with like outbreaks or any kind of foodborne, or do your environmental health people have to go and?
We have all our partners in the Department of Environmental Conservation would be part of sustaining this effort, and then our epidemiologists do surveillance and testing, and our public health nurses would help us continue to monitor. So between those 3 legs of the stool, that's how we would handle all of those assessments, and they all came out to be part of this. So here's just a sample of things that are provided. Things for wound care, catheters, pressure ulcers, so a lot of the population that we're talking about, the kinds of supplies that they would need, ways to get people oxygen. Interestingly, at the federal level, one of the things that they looked at in shelters and medical shelters is usage of electricity. And they started seeing these peaks in oxygen use. And they figured it was after a couple of days people would need to charge up whatever devices they were dependent on, or run out of power sources, and then they would come to, they didn't need the medical care, but they needed the power. So they would come for that. So that's been a big part of a medical station. And then of course,
we've had issues like at our shelters with CPAPs and those kind of things.
Yes.
That patients show up with that we may or may not have power to recharge them or plug them. Generators.
Yeah. One of the things that our state has put money towards is generators. So we have a cache of generators, and our region has also donated older generators that they were getting rid of. And so we're working on a generator cache, and so to build that capacity, because we are so dependent. Everyone is, but we're just farther away from the the electrical cord where you can just keep attaching cords. We're farther away. We need more extension cords. So it's a huge issue. I don't know. We're kind of top on the list of getting generators though. We have good emergency management partners. Okay, so here's just the wheelchairs on the list, and that's a hand wash station right there, and there's the oxygen generation equipment. All right, so here you see our pharmaceutical cache. It is exactly that. It's all locked up and secured. One of the things we learned in this exercise is don't put this in the middle of your room. It's really hard to keep secure. You want it backed into a corner or in a separate room where you can keep it secure. I don't know why they thought the middle of the room would work, but not so much.
Maybe so everybody could watch it get broken into?
Yeah, maybe so. Well, I think the thinking was it was centralized, so everybody have easy access, right? One thing we don't have yet in our cache is narcotics, because you use the whole DEA license issue. And it's just a whole another level of security and all the protocols you have to have in place. So we hope to get there, because honestly, pain meds are one of the things people are going to want and really be demanded. So.
How long can you keep those meds without having to dispose of them?
It varies, because we ended up doing a year's worth of research on what we should put in our pharmaceuticals. So we went and looked at our Medicaid billing, what are the things that are purchased. We looked at the federal supply list. We looked at all kinds of different data. In the end, we decided pretty much to match the federal cadre, because when they come in to resupply, they'll bring that and it'll be consistent. So other than augmenting pediatrics, we pretty much kept it the same. And that varies by what's in the pharmaceutical cache. We're fortunate to have a pharmacist who takes this on as one of the things that he does to keep that rolling list. And so we timed our purchases too to max the life of the pharmaceuticals. So, but it has to be in your budget to restock it. Because if you're going to do it just in time, it's going to take a couple days to get there, so you can give you the first.
Now, do you have a physician that actually is there 24/7 with y'all that is writing the orders, or how do you know what the patients are on? Or
yeah, there's a medical director that goes with the medical station. Now we do this all creatively, so this is, remember, we don't have standing staff the way the feds do, where they can just call on people and go, your task, go. So we staff this through our volunteers, our state staff, and our guard partners, and our Alaska One DMAT team, Disaster Medical Assistance Team. They're given special dispensation. Normally, DMAT teams don't operate in the area that they live in, for obvious reasons, because they would have jobs in the area. You don't want to pull them from their regular jobs. They may have been affected in the area, but we were like, what you gonna do? So they let them exercise in this as a federal DMAT. Otherwise, we would have had to hire them as state. So we rely on all those resources and put them together. And we had a volunteer medical director. We trained
just for the non-EM people. What's a DMAT?
Disaster Medical Assistance Team. They are commonly used as that sort of first round of responders in an incident, and so they might be, they could be paramedics. They have different levels of medical skills, and they also have a lot of logistics experience, so they can set up and support things like a federal medical station. These are the tri-walls. They're all the same length and width, they just vary. There's 2 different heights. And so all the stuff that you get is put in these cardboard boxes called tri-walls, because it's tri-ply cardboard. It wasn't construction paper, I don't know. I was flying a red eye not too long ago, so excuse my little glitch there. And they have a plastic lid, and so that you can stack them. They're sturdy enough to stack. We learned a couple of interesting things. So here's how you identify the contents of each one of those boxes, and it's all very nicely labeled and everything. And you know how when you purchase something through the mail, you get those packing slips? They're the plastic sealed to the cardboard, and then there's paper inside. That's exactly what these are. Let me just say, when you're a National Guard or transporting them down the highway, that if they decide it's a sunny day and they don't need to tarp it the way it was in the prescriptive mission assignment, that you will find that your highway is littered with all of these things. And when you arrive at your destination, you will no longer know the contents of everything. You will only know the contents of the things that did fly off. That's another little after action we'll take care of in the future. As we re-inventory everything and put it back in, we will come up with a system that will endure transport. All right.
Is that some of the stuff FEMA learned?
What's that?
Is that one of the things that FEMA learned?
No, that was one of the things we learned. I don't know how they do it, but that's how we did it or didn't do it. So we said earlier it was a building of opportunity you look for. These are the kinds of buildings that you could put it in. And in Anchorage, we've looked at all of these and assessed them as to whether they work, like the high schools, the malls. Well, we haven't looked in cruise ships, but we have that as a concept, since we have all of Southeast and all those cruise ships. And certainly there's a precedent for using cruise ships. The railroad. Our railroad is interesting. It has enough power generation, it can power a village. But we can never get them to exercise it. They're afraid it won't work. And I'm like, well, wait a minute. We'd love to do that. So how do we get people? You know, once you stand up a medical capacity, people are going to come, right? So you can have this concept that it's only low acuity patients, and that's great for you and your staff, but the fact of the matter is people are going to walk in with everything, with anything, right? In a disaster, if they see there's help or they hear about it, they're going to be there. So we figure they can come in all these different ways. They can walk, they can come by bus, they can come in a personal vehicle, they can go by EMS, they can come by police or fire, or, you know, in Joplin, they were just, you know, people were just in the back of anybody's truck that could get through, however, whatever, right? So we told our, as we were planning all this, and our Alaska Respondees, our VIP, licensed volunteer healthcare professionals, were working on how this would all work, and they're like, we don't handle that kind of stuff, that's too much, to be honest. And I said, well, you have to plan for this, regardless. So that's what we're planning for. All right, next slide. So this is how the flow would work. And I put in some of the pictures from our exercise. So this is our concept, is that a patient comes in however they get there. And on the left-hand side, we're going to say they meet the criteria that we set out, right? So this is maybe a gentleman, he's having maybe some respiratory issues, I'm guessing. His patient card for the exercise said, oh, I'm having trouble breathing. So potentially that could be a good candidate. Now, if it's because he has like crushed ribs and other things, that might not be so much, but let's go with that idea. So if they meet the criteria, we can admit them, and there you see they're going through the admission process and the paperwork. But then again, maybe they don't meet the criteria. So first of all, we're going to be responsible first we have to figure out whether they do or don't meet those criteria, right? So that's the first round of triage. Then, if they don't meet it and they need extra and they need care, we're going to have to stabilize them somehow. And so we figured, we need high acuity care, and we need somebody who can stabilize them. We were good partners with Samaritan's Purse, and for those of you who don't know, they're a non-governmental organization, and normally what they help us with in Alaska is they rebuild communities with us in partnership. But it turns out for international disaster relief, they have medical teams. They have 600 physicians and nurses who do international disaster relief. They don't exercise in the U.S. until now because they don't ever plan to do national response except in Alaska, where our conditions are very much like the ones that they work in all the time. In fact, we didn't think they were going to plan this exercise because as late November, they were still responding in the Philippines, right? So we thought they'd be exhausted and, you know, say, okay, we don't need to exercise, we just did this real world. But what our wonderful partner said was, you know, we learned a lot in the Philippines, and we need to reconfigure our field hospital. We'd like to do that and come up and test it in your exercise. I'm like, okay, let's play. So the pictures that you see here, that is a Samaritan's Purse OR team getting ready to do surgery. Because they actually can do 2 surgeries at a time. They have an anesthesiologist, they can do blood work. It is amazing. It's phenomenal. So they can stabilize, in fact, they can do very high level medical care, but not for 250 patients, they can only do it for a smaller group. And then we would want, after that, to somehow get them moved on to definitive care, presumably through patient movement, because now they've stabilized the patient, that makes them more likely to be able to fly. Now, they could just not meet our criteria at all. I mean, they just show up and they don't really have any particular needs. Maybe their needs can be met at a congregate shelter, and we just need to figure out how we're going to get them there or send them home or whatever we're going to do. Oh, the one thing I didn't mention was, what if we need to transfer them? We did actually practice 1 helicopter flight. So we heloed from the medical station in Samaritan's Purse to the Matsu Regional Hospital, which is the nearest hospital. Other than that, we weren't worried about transportation, other than our volunteer patients we bussed in, but we didn't practice EMS bringing in patients and them coming in cars and vans and vehicles, because you have to pick and choose the things you're going to exercise in something this big. So here's how it kind of works in the big scheme of things. You have an event, you have your local hospitals, they get overwhelmed. We have our Alaska Respond, which are our licensed healthcare professionals. And then we have our federal teams, the DMAT team we talked about, anything that would come in through the EMAC, Emergency Management Assistance Compact System, and our military partners. and not to mention HHS and US Transcom and all of the providers who bring in various and sundry teams. So that's kind of how the whole thing is. It expands from it being small to being overwhelming. And next slide. And here's what we said about priorities for the medical station. I think I slide that over there. We said, well, you know, first of all, our priority one really should be, oh, you know, if they need wound care, if they have chronic medication, they have to be monitored by medical staff. They're equipment dependent. They need electricity. They need a support for medications. Even mental health conditions, you know, we can handle them if it's something where they're not actively psychotic. Our priority 2 will be they don't need quite as much help. And priority 3 would be really they can function independently, but for some reason they're not a good fit with a congregate shelter. Or maybe they've come in as a family unit. We wouldn't turn families away either. Because we want that family there to be able to provide support for the person who needs the medical care. So we look at that as kind of a whole family condition. All right. Do you think those are good priorities?
I have a quick question. I see priority 1 is the priority for accepting them into
once
your
they're in
alternate care
AMS.
site. Yeah. Some of the stuff that's listed there seems to me like they would be able to be in a general shelter that's integrated.
Yeah,
like
we're really looking at
assistance with
overflow.
medications or
Yeah, we would be meeting the need if it weren't already met in a congregate shelter. We would work to help the congregate shelter meet those needs. But we're looking at, in this 64 earthquake scenario with the 9.2, we're thinking that they probably don't have those capabilities. Yeah, as opposed to like the average state federal disaster. Good question. All right. Oh, just quickly, can you just tap through all those? There we go. All right, so if they need a lot of medical oversight or ventilator management or dialysis or life support or total care, that's kind of beyond what we can do. All right, so how does this whole process work? I mean, when you step outside, now you're not looking at the medical piece, but you're looking at the whole emergency management piece. How does that all work? And how did it work for us in this exercise? Well, we had Matsu Regional Hospital, which said, in this event, wow, we're overwhelmed, we need support. The Matsu Emergency Operations Center, which is at the borough level or the county level, said, hey, we can't help them, you know, we're done, help us. They go to the State Emergency Operations Center. Now remember I said we had a Department of Health and Social Services EOC. There's also a state EOC, and the state EOC is the lead agency for support, but we have a separate EOC because our stuff is so complex, we don't want to get it lost in the state EOC. More on that later. So our State Emergency Operations Center is going to look at that request and then give it to us. So they're going to make sure that it's documented in the system, and they're going to say, oh, that one's yours. You handle that. And then we're going to say, whew, by the way, they don't request a medical station. They say, we need support. We think we're going to have a couple hundred patients. We think we're going to have actually many more patients than that, but of those, a couple hundred are going to be kind of this level of care. They're also sending us requests for higher levels of care. And the way those work is you're not supposed to say which resource you need, you're supposed to say what capability you need. If you have a problem, here's where the problem is, give us a solution. And we, the state, sometimes with federal support, will determine which solution to give them, okay? So they said, okay, we've got a bunch of patients who need care. We look at it, do more research. That kind of information sharing that Roger was talking about earlier is critical here. So we're going to validate that it's an actual need. Then we've got to figure out where we're going to put it. Does it have what we need to support it? Does it have power? And all of those things. Is it safe and secure? And then now you get into the, now you're going to start seeing a lot of abbreviations. PSMA, Prescripted Mission Assignment. This was the one thing that worked really, really well. We worked with the National Guard in advance and said, we need you to take the medical station from the warehouse, load it, and transport it, and set it up. And that's 4 different processes. We had 4 different prescriptive mission assignments. We met with them, and this was all worked out in advance for any response, not just for this exercise. So they know exactly, when we say we need this, they know exactly what we're both expecting. We both expect and therefore deliver the same thing. So we don't have different expectations, we don't have to work it out. in the midst of a disaster, it's done ahead of time. Pre-scripted mission assignments. We do it ahead of time, it's a specific thing, and it's given to a specific entity. Works great, or at least for us it worked great. Not so much with a lot of the other resources that were ordered. And that goes to the Joint Operations Center, which is on the military side, to make those things happen. And then just all kinds of things are cascading from there. So you look at, you need to start thinking about how you're going to staff that AMS, how you're going to transport it. Do you need additional support, like through Samaritan's Purse? Are you going to bring in that additional capability? Our forestry division uses our comms equipment all the time. Basically, we give it to them, and we say, if we need it, we want it back, and we're going to ask for one of your staff to support the comms trailer. So they're experts. They use it all the time in wildfires. So we don't try to be the experts. We let them do it. So they do our comms, so we can be sharing information. You need wraparound services. How are you going to feed these folks? How are you going to feed your staff? What are you going to do about, porta potties? And by the way, are they, disability compliant, ADA compliant? All of those things, if your facility doesn't come with it, you're going to have to figure that all out. So power, waste, and food. Then we go to where we store it is at the 673rd War Reserves Material Warehouse. It's just the warehouse. And then for our pharmaceuticals, we store them in another partner, Alaska Native Tribal Health Consortium. So we need to get all those people playing together to get us up and running. Our goal is to get it up and running within 24 hours. Don't know if we'll always be able to meet it, but it's a good goal. We did it this time, but it was an exercise. And we were a little bit prepared for it. And then we're going to request federal support right away, because we know we don't have the capacity to sustain. So one little thing results in all this and more. All right. So that's just a map of how where the medical station is going. It's going from Joint Base under Richardson to the Alaska State Fairgrounds. So from Anchorage to Palmer, which is right outside of Anchorage. And then this is how it was all set up. So we had a location for the AMS was in a building. Now Samaritan's Purse, they actually have a tent. And actually they have a base in Soldotna, so all they had to do was bring their tents to Palmer. And then they flew in their equipment and their staff. So they're halfway there just by being in Alaska. And then there was also a place for volunteers and then just various parking places and a place for the helo to land. Now here's the unloading of the Alaska Medical Station. So all those tri-walls filled with all that stuff is coming off of the long haul trailers, and then you see the person in charge of the setup, he's got the map, so that was all arranged in advance as part of that pre-scripted mission assignment. They know what to do and they execute. We thought it would take from early afternoon all the way through the night to get the setup. They did it in something like 4 to 6 hours. It's hard to say exactly where it starts and stops. So that's just the process of setting it up. So what does it take to do all that? Well, this is just for setup, just to give you an idea. We had 23 National Guard, a couple of DMAT members, because you want the people who are going to be using the facility to be supervising the process of getting it set up. Because they ultimately have autonomy to say, this is going to work best for what we're expecting in terms of patient flow and whether in terms of our medical needs. So that's what we did for that. Okay. And here's what the map looked like for the medical station. And next slide. Sorry, here's our just-in-time training, because we use a lot of volunteers. So this is our last respond volunteers. Next. This is our first patient coming through. You can see everybody's got the ICS label on the back as to what their medical position were. These were the people as they were coming into the system and being assessed or being treated. You can see our National Guard partners being part of that process. Here they're in the treatment area. And I think there's one more. That's our behavioral health folks, and they're talking about doing behavioral health assessments. We tested out a tool called SciStart. Your previous speaker talked about Jumpstart. SciStart is the psychological equivalent for triage. All right. Okay, so this is the first time a surgical field hospital was co-located with a medical station. Next. So this is the Samaritan's Purse tent, and there just happened to be a totem right next to where they stood up, phone pole. Here they're assessing, and they're doing their non-surgical capabilities, so more on the medical side. So that's their team, and then here you have the OR functioning. So they handled 63 high acuity patients in 7 hours. Now we split those hours across 2 days. The first day we only operated for 2 hours because we had never done this before. We wanted to give people a warm start, get enough information to allow us to reset. So at the end of the day we did a hot wash. Our leadership team sat down and said, what do we need to do differently? Which was patient flow, because they got everybody. They were only thinking the low acuity patients, right? So when they started getting those trauma patients coming in, it got a little chaotic. So they had to figure out a different way to make the patient flow work. Right? So we did 2 hours the first day, 5 hours the second day. And so here's what we learned. Partnerships, plan, train, and exercise in advance pay off. Prescriptive mission assignments do get things done. Adding your high acuity facility sounds great, but it actually created a lot of issues. Things like patient flow. You got to rework a lot of things when you add that capability. If you give your clinical teams a lot of admin support, they can get more done. So for every person, we would now add at least a scribe and a runner. If you need somebody who can help with your documentation and take care of that, and you need somebody who can just go do run get something or go do something for you. So you can't have too many runners. You've got to have on-scene logistics support and EOC liaisons. I was there Thursday and Friday making sure that things got set up, and I was on the phone going, we need this. The food arrived 4 hours early. You know, it's all this stuff, and I didn't have any support, and we had planned for them to be there, but they decided as an exercise inject that in reality it wouldn't really get there in time, so we were just going to have to manage on our own. It's like, no thanks. Radios. Funny story. We thought we had lots of radios. We didn't. We did, but we didn't. Not have enough. And they thought they were the plug-in kind, rechargeable. Not so much. So they didn't know that you could also have regular batteries, and so yeah, we were a little short on batteries. Have a media presence with PIO support. This is going to have high visibility, and people are going to care a lot about this. And you also want to try to manage who shouldn't be coming there. You might not be successful, but it'll help, right? So minimize the number of people you don't want. In our exercise, we did 12 media interviews between Andy Jones, who is the incident commander, and myself. We did 12 media interviews in one day. And meanwhile, the governor visited for an hour and a half. Now, that was not a surprise visit, but we were told that most of it would be 25 minutes. But you know what? He was really interested. And he's great partners as well with Samaritan's Purse. So yeah, that's a picture of our governor's, the third one in row. That's Lance Plyler, who's the medical director in charge of Samaritan's Purse, Luther Harrison, who's vice president of Samaritan's Purse and one of the most wonderful people on the planet. And that's Barry Wilson on the end, who's their logistics manager. Okay, so staffing with volunteers increases your challenges and your rewards. It's really hard to depend on volunteers to do something like this. You've got to have some core capabilities beyond that. They're going to come with a lot of different experience and things they feel okay about doing or not okay about doing. So you got to have assignments that fit their abilities, even if they're trained in advance, even if they're all registered and so forth and so on. You still got to work that. And doesn't mean you just get low acuity just because you think you are. And we think it's important to plan for various transportation needs, but we didn't include that except for the helicopter in our exercise. So we would look at doing that in the future. And nothing can replace exercising. Beyond just the opportunity that people had in the exercise, now we have all of these photos, we have some video, we have media interviews, we have a ton of television coverage for all of the things that were going on for Alaska Shield. So now when we talk about this to people we want to have volunteer or to understand what's going on, we can actually reveal it to them using Alaskans practicing in Alaska. And so you just can't beat that, and it extends far beyond the whole cadre of people who volunteered. So how's our medical station? Patient movement. So just a little bit, I'm not going to go through all of this, but just to give you an idea, we have 24 acute care hospitals, 2 of them are military, we have 1,429 beds in Alaska. I'm guessing that's about how many you have in just one area here. Most of them are in Anchorage. We don't have burn beds. All of our burn patients go to Harborview in Seattle. That's our nearest level 1 trauma center. So all of our aeromedical is all private and contract. So in other words, we don't have a lot of natural capacity, and we're always at our pretty much our beds are full, pretty much all the time. And you could click through there. That is showing you our intrastate movement from Valdez to Fairbanks. It's quite a long distance, halfway across the state.
I'll say, can you, for people who don't understand the size of Alaska and how far that is, do you have a corresponding?
Well, how many miles? It's an 8-hour drive if you were transporting by ground.
So if you took an image of Alaska and you transpose it on top of the lower 48, it covers about 50%.
Yeah.
So the bottom of Alaska to the top of Alaska is about the distance from the bottom of the contiguous United States to the top.
It's an hour plane flight in a fast plane. It's an hour and a half in a slow plane to go from Valdez to Fairbanks.
And most of that is 2-lane road still.
Right. Right.
Mm-hmm.
Yeah, I was laughing at the traffic reports this morning because it was all the different, and I'm like, wow, we just have the Seward Highway and the Glen Highway.
Yeah.
That's really easy.
Unless it's winter, because a lot of those 2-lane roads are then covered in snow and ice.
Ice, right, and that's ice road truckers.
Yeah.
Okay, next slide. All right, then here is just click through. All right, and then on to the next slide. And just keep, so this is showing you our interstate or out-of-state patient movement. And if you could click through this really quickly, it'll animate for us. So now you have multiple hospitals that have reached their surge capacity and need help. And they're going to transport to what's called a disaster aeromedical staging facility. That's where the feds come in to help you. And that's where you stage all of your patients and get them ready for transport. It's where they're validated for flight by a validating flight surgeon who is owned by U.S. Transcom. What does U.S. Transcom normally do? They're military. They usually fly wounded soldiers from a casualty collection point right in the field where they were injured to wherever they're going, either a temporary destination or a definitive care point, right? So they're configured for that. And so when we talk about all these hospitals surging and coming to a different point and they talk about doing civilian support, it's really different. Because why? We have pediatrics. They don't usually deal with kids. They really have no capacity to deal with kids. They don't have the equipment. They don't have the training. Right? They're not usually dealing with bariatrics because in the military you're not going to meet those criteria. You're not going to be in the field getting wounded. In other words, so they're used to dealing with healthy young adults who have traumatic injuries. That's pretty much it. So it's a really different system, but the idea is the same. You gather up the patients, you bring them to a center point, and you transport them out. All right, just keep going to the slides here. This is showing you just movement. Okay, so this is when you're moving patients out of the state, where are they going? The VA, the Veterans Administration, has responsibility for coordinating hospital care outside, in our case in the lower 48. And we had 6 different VAs participating. Salt Lake, Boise, Bay Area, Portland, and Seattle. And in fact, we actually have a picture later on of the actual arrival in Seattle. So I'm not spending time on this. I never meant to spend time on this, but this was to give you an idea of the planning process for doing this. So, in other words, we worked with a lot of folks and we went through a lot of things. And really, that's all I really meant to say. You got to think about a lot as you put this together, and you think about doing it, especially in state where you're not getting federal support. So all the things they've thought about in advance, you need to start thinking about if you're going to do your own. Right. And here is more planning. It shows you, well, there's an affected area, which is the dark area, and then that circle grows when you talk about the response area, right? And so you have to think about what are the resources that you have on hand, so you want to know that in advance, so you can figure out what's the best solution for us. What could we use of what we have in state, or are we going to have to go out of state? And then, so we went through that planning process, and we looked at the way the feds do it. Down there in the right-hand corner, that's the actual plan for out-of-state patient movement. Looks complicated, doesn't it?
Yeah.
It is. That's why I'm not trying to explain it to you today. And this is our State of Alaska Air Medical Coordination Group. Originally, we thought it'd be like, we were supposed to put together this medical task force as part of our state emergency operations plan, and we thought, well, it'll be physicians and surgeons, and they can tell us what their patient needs are and all that. Wrong, that's not really what it needs to be at all. It needs to be all the people who can bring you resources and you aren't going to pull away from clinical care. You don't want to pull away your physicians and your surgeons from doing clinical care. You want to get information in other ways if you can. So this is our air medical coordination group. That's just for doing the flights in state. And if you click through, you'll see that in magic animation, it turns into, because we do air coordination all the time, we do medevacs every day, lots of them. One day when I was working for the North Slope, we did 17. That's almost a mass cash. So it turns into our medical task force, and here's just a list of who the feds involve when they're doing out-of-state patient movement. In other words, you have a lot of partners and they have a lot of procedures, and they want you to follow all of them. That's the important lesson here. It's complex, and you have to do it their way. They are not flexible. And this is the kinds of things that they can bring, and I show this to you not so that you now know what they bring, but if you look through all of here, how many terms do you recognize? E-meds. You know that if you're gonna ask for a medical station, you want to have E-meds. E-meds are your expeditionary medical support team. They're going to be there first and doing that first round of care. And whenever you order to do anything, always add E-meds. And a plus 25 means you're a plus 25 person, and a 2X, that's a 2-day resupply. And let's see, the CCAT, Critical Care Airport Transport Team, the EDOCS. Well, many of you may know Suburnia. I'll give you that if you know emergency management for chemical, biological, radiological, and nuclear response. But there's all kinds of things that you need to learn. It's a whole new vocabulary on top of the FEMA vocabulary. And here, our previous speakers have all talked about the importance of communication. Here's the kind of information that we ask for from in-state patient flight. It's, who's coming, what's their history. We don't need a lot. We just need to know what's bringing them to us today. What are those critical issues that we need to be aware of? Do they need a critical care team? And so forth, things like that. We modeled it after the federal system, because we only wanted hospitals to use one system. So we adopted the feds. We didn't try to make them change to fit us. Okay. This is our common operating picture tool. Highly recommend it. We haven't worked out all the kinks yet, but this is so we can all share information in real time. So this is listing our beds and other assets. We tested this out in the exercise. We have a long way to go before we're using this every day. And this is a summary of what's available across the state, so we can do a bed count. You can look at all that. You can see it's still in the planning stages because everything's 0. We're not really at 0. And then you can look at things like your red, yellows, and greens, and whether they're at the medical station or at a facility. So this is where we hope to go within the next year. And just more information. This is nice because you can chat with people in this open environment and everybody can share information. So it's a real friendly environment. It works off of the image trends. A lot of EMS programs use image trends as their data collection. That's why we picked it. All right. That's some background. These are all of our healthcare coalitions. So I thought if anybody was from Healthcare Coalition, you want to see that. And now we get back to the actual exercise. In the upper left-hand corner, that was actually, it's kind of a skewed photo, but we set up the AMS in a training session in November because we did a whole conference around the medical station, so people could learn what they need to support that. And that's a system that's very similar to what we purchased. That's our rural system. This is our actual flight from, I'm going to say Valdez. And the tents over there are, we just got those donated from the Indian Health Services through our tribal partners, and they're Blue Med tents, just another capability that we have. So we talk patient movement systems if you need somewhere to put them after you move them. These are some of the things we have available. And, okay. All right, I'm going to go really quickly through these animations, hopefully. So, can you just keep going? Yeah. So here's really important things. You've got to keep information going, and in a routine event, it's just going to be going back and forth from your hospital. It doesn't involve the state. It doesn't involve the region. You can make things happen just through your routine everyday operations, right? It's pretty simple. You can use medevacs, you can use ambulances, but you don't need to involve a whole bunch of folks. It's just routine. When it gets to the next level, and more things are going on, then you might call on the state and say, we're overwhelmed, we need patient movement requests, you're going to use the state or our emergency operations center, we're going to coordinate overall flights so they don't get co-opted. We had this happen in other exercises where one entity says, I need all your medevacs, and they take all of our resources and nobody else has them to use. So we said, nope, that's going to happen through the state. So you have to, in this whole process, think of it. The hospitals want to send you everybody they can. And who do they want to get rid of? All their critical care, all their peds, all the things that take a lot of staff, right? But that's the thing you're least able to accomplish when you do air transport, for the reasons that I just talked about, right? So you've got to come to some sort of an agreement. And guess who's in control? The person doing the flying. The person sending you stuff is they're out of control, or not out of control. They have no control. They can tell you what they want, but you'll tell them back what they're going to get. Okay? So the patient manifest is what gives you that. That's that final piece of paperwork. And so here is what happened as a result of all that paperwork flow and all those common operating picture things that you saw, all those forms. They're really, really important. That's why I spent time going through them. Hospitals hate them, but it's like, we do interfacility transfer all the time. This shouldn't be a huge issue. So those were some of our, that was our Valdez patient movement. In Valdez, they were actually doing a glacier and a water rescue. So you see a picture of each. You see EMS transporting, and these are in the bottom three are the hospitals actually receiving those patients as part of an actual search and rescue exercise. And they, for real, had people for miles along the water and pulled them out of the water. Coast Guard, Alaska Coast Guard, good thing. This is a alternate care site. So the hospital was overwhelmed, the community was overwhelmed, and we had National Guard stand up an alternate care site. So they were actually providing treatment to patients in those first days, just because they happened to be there doing volunteer work. And so that's what you see there. And here you see the actual patients being transported. They actually flew, 15 of them, from Valdez to Fairbanks via C-130, courtesy of the California National Guard. And the red that you see, once they get ready for flight, they change the color down to red. And I was on one of the prep flights where they got the patients ready, and they actually did a disco thing to calm, it's like they did a song and it had to go red, green, red, green, red, green. But they say they're changing the color from red because they can't read the monitors. So they need to pull the lights down. It's less of a power use, but they can't do that, so they're changing it. So just in that way. And here you see the receiving end. So here they're coming off the plane into an ambulance. They're going through the airport. You can see the 50th anniversary logo right there. That's the airport with the grizzly bear over in the right-hand corner. And here are Fairbanks Memorial Hospital receiving patients as they come in through their surge. All right, so really quickly going through here. Now we're adding another layer. You thought it was complicated before? Now it's the feds. So this is why we train at the state level to do all this stuff, because it's got to go through all of those processes before you get an okay, I'm going to take your patient. And even then, once they get to the DASF, that staging area, the validating flight surgeon can say, you know what, we can't take that patient. And that is what in-state or out-of-state patient movement looks like. It is that complicated. It is kind of a last resort. And here's pictures of our out-of-state patient movement. You see the hospitals gearing up and figuring out whether they have met that surge capacity. And here you see patient transport. We only had 3 ways to move patients: via ambulance, via a dual-use vehicle, which is owned by the VA, and an ambubus system. So you can retrofit your buses. That's what Anchorage just bought, and we tested it out. So that's where you see them. They're on buses on that part. And here is JBEAR, 673rd Hospital. They actually stopped operations for a day so they could exercise. They lost $1 million playing in this exercise. And here you see their processes, and you see even in the exercise people get overwhelmed. They have to take a pause. So imagine what it would be in a real world event. And then here you see what's going on at the disaster, the DASF staging facility. So that's what's going on there. And you saw the tubing, one of those patients was critical care. Health and Human Services provides a critical care team. That's a new add to what the feds do. And here you see actual patients actually being loaded on and ready for transport. They didn't actually go from Anchorage to Seattle, but they picked up a new load of volunteers from Seattle to all the other 6 areas. So they did do 6-state movement. They just skipped over the Anchorage-Seattle part. What do we learn? Again, partnerships pay off. When you don't have mission assignments, nothing in this federal process made it all the way through in the timeline for the exercise. Not 1 quarter. We just did it anyway, but that'll never happen in the real world. All this is complex, and in after action reports, we had people on the federal side saying, well, so few of us understand the National Disaster Medical System. And we're like, okay, because it's complicated. And their throughput maximum per day is 540 patients. So you can't rely on this in a really catastrophic event to be your only solution. So what you want to do is think about what else you're going to do. What else you're going to do, and how do you make decisions about who's going? It's the state that decides. Ultimately, the feds say yes or no, but you've got to prioritize. So you've got to decide, are we going to take more bariatric patients and fewer patients overall? We're going to take more critical care, but fewer patients, because for every critical care patient, that's 4 more people who don't get to go on a plane. Because 1 critical care patient takes up 5 berths, because you saw they were stacked. They're stacked 5 high in a plane. So 1 critical care needing an attendant, they can't put more patients in there. So you pay a cost for all of that. This whole thing isn't flexible once you get to the federal level. You do it their way or you don't do it. I just said, we have a huge role in figuring out how this is all going to happen. And ultimately, that's what we tried to practice was, how do we do this? How do we actually do this and succeed? And again, I try to show where it's similarities and differences between now and the medical station, and nothing can replace making it real. The very last thing I want to say is close your feedback loops. What do I mean by that? You need liaisons everywhere to get that information flowing back and forth and to make sure what you think is happening is actually happening. And if at the state emergency operations center or when it goes federal to the joint field office, if you don't have someone there who's both knowledgeable and who's a leader, you won't succeed because you won't get your stuff pushed through as a priority. It'll just get lost in millions of other things. And even then, you're going to have problems. So there needs to be somebody who understands the missions and is considered a leader. He's going to step in there and be an advocate and say, get this done, and follow it through. You've got to have liaisons wherever you're having operations, and you have to keep your critical information current. You have to figure out which stuff is important. Like Roger was saying, why do we care about fatalities? We're a hospital. We're going to manage people who are still living. Figure out what's important and make sure that you've got a way to keep track of it. And I'll specifically say keep track of your resource orders, because it's dollars to donuts. Most of them won't get filled unless you have somebody on it going, where is it, where is it, where is it? Everything from blood to patient movement. You have to do that. You have to have people dogging everything along the way. It doesn't just happen automatically. This page, this is what I have to say that I think applies to anyone doing any of this stuff. And you've got to use ICS, Incident Command System, because you have so many partners. And you have to have some common way of talking. And that's, at least for now, what we learned. We haven't actually had our final, we don't have a draft after action yet. We haven't had a final after action meeting. So you're really early in the process. But thank you for letting me talk about it and share pictures and experiences with you. Questions?
So we're still on the premise of the quantity.
So we ran, I'm sorry, I think I accidentally flipped that. So we ran 345 patients through our medical station in 7 hours. 60-ish of those went to Samaritan's Purse. And we had 245 patients actually flying or ready to fly.
What I'm saying, for your bariatrics and over your critical, we're still with the CERT. We say quantity first.
Right.
Okay.
Oh yeah. So you would try to get more people out and keep your bariatrics.
Yes.
That's kind of what we ended up saying too. I think that's a good call. I mean, everywhere's going to have a different call. Which do you take care of more patients and move them out of harm's way and get them to care, or do you take your highest needs patients and move them? I think you're on the right track by saying you keep your highest needs and you move as many out as you can. But you got to have a plan to get them back, by the way. You definitely want that plan, and that's another place for feedback. Where are our patients? When are they coming back? How are they getting back? And if you one more recommendation. If you have trouble getting your hospitals to play as we did, promise them this, which I got a Region 10 to promise after the exercise. They will come in and explain how reimbursement works to hospitals. You will play in our exercise, we will come explain to you how reimbursement works. That is a way to hook hospitals in.
I'll be communicating that to our Eastern Virginia Healthcare coalitions.
Yeah.
They're having issues with getting hospitals to exercise.
Yeah, it's hard. Well, they have to take staff time and it's expensive and it's a big deal.
Thank you. Thank you, Mary. Okay, so I think we have
We don't have
4 things real quick to give away, and then here.
It's not too late.
Does anybody else need a ticket real quick? Yeah. Okay. 634. Oh, Cheryl, go. So Cheryl, you can. There's 4 things up there: a whistle, a flashlight, an emergency backpack, and a hand crank radio.
Cool.
612.
Nope.
615.
Nope.
617.
Nope.
Oh, I'm 615.
Oh, you're 615.
Are you?
I'm 615.
Well, there you go.
Woohoo.
All right, claim your prize. 635.
Oh, that's you.
Oh, there you go.
Go claim a friend.
Got 2 more left.
Get that
627.
radio.
627. 626.
That's right.
Okay, here's a shocker. 625. Let me mix these up. 617. 639.
Gonna have big old
624. 621.
621?
621.
Yeah.
All right.
We have winners.
So you have a.
Oh.
All right, in closing, everybody, first let's give Dawn another round of applause. She did an amazing job organizing this event. I'd also like to say thank you to Mary Carlson, Eastern Virginia Healthcare Coalition, and Donna Grimm for their excellent presentations today.
Yes.
One more round of applause.
Yes.
And before we send you off to fight traffic, I want to thank you again for coming, of course, and you found this training beneficial and engaging. We'll be sending each of you a follow-up survey tomorrow, and we sincerely appreciate your honest feedback so we can continue to improve future HOEPS events. Is that how you say it?
Oh, yeah.
HOEPS, okay.
I've tried to switch the E and the P because
I know.
we're not doing
Please remember, Preparedness is an ongoing event. Each year we wonder how we can provide more opportunities for you to get guidance and training in emergency preparedness and response. But other than encouraging you to connect with your emergency manager, there has not been much opportunity available to you until now. So once again, thank you everybody. We appreciate you coming. Have a wonderful day and be safe driving home. By the way, it's Earth Day, by the way, too.
Thanks.
Thanks.